Welcome back to our final session on healthcare in State of Mercer County 2012. And I'm delighted to welcome our guests, Assemblyman Dan Benson from the 14th District, and Anthony Skip Cimino, as everyone knows Skip, who is the President and CEO of RWJ Hamilton Hospital. Welcome to you both. Thanks for being here with us this morning. Why don't you tell me just a bit about your role, let's start with you, Assemblyman Benson, in healthcare. Your
sure.
Focus on healthcare.
Well, my main role currently, besides representing the 14th Legislative District, I serve as Vice Chair of the Health Committee and served on the Health Committee for the past 2 years. And then prior to that, serving at a county level as a freeholder and as a council in my hometown of Hamilton Township.
And you were actually one of our panelists on our Council on State Public Affairs State of Health.
Correct.
In May. We were delighted to have you there.
Thank you so much.
Thanks for coming back to join us. Skip, tell us about what you do at RWJ.
Well, I've been president and the chief executive officer of Robert Wood Johnson Hamilton since June of 2009. Prior to that, Becky, I have been on the board at Hamilton from 1988, so 1988 through 2009, at a period of time in the mid-90s from 1994 through 1999. I was the chairman of the corporation and was one of the individuals who took the then Hamilton Hospital in concert with 2 or 3 other individuals and merged it with Robert Wood Johnson because we thought merging our community hospital with a academic medical center that provided tertiary and quaternary care was essential to the residents of our community.
Great. And you know, just a note before we actually get started in the healthcare discussion, we chatted a bit during the break, but is with the last panel, talking about the integration of, as you mentioned, the integration among education officials, among elected officials, county officials, is very striking in Mercer County. And I know, Skip, you're a trustee here at Mercer County Community College.
Yes, I've served here as a trustee and as chairman of the board. I think what's, you know, everyone says each county is unique, but I do think what's very, very unique about this county is the level of collaboration that goes on between the business community, the community of government or elected officials, the colleges and the vocational technical school here, as well as with the healthcare community. So in our instance, in collaboration with Mercer County Community College, we provide a great deal of education for their nursing students. We have a a simulated man, that we've done in collaboration with Mercer County Community College. Many of our licensed technicians come out of the vocational technical school system. And we've worked collaboratively with the Mercer County government as well as the Hamilton Township government, not only from the standpoint of the things that the hospital may need, but also with the occupational health services that we deliver to county government as well as to the Hamilton Township government, the municipal government, as well as the Board of Education, in ensuring that their workers continue to be productive in their various aspects of life.
So you can see a direct correlation then between what you're doing and how that articulation actually improves the quality of health care for Mercer County residents.
Absolutely. There's no question that is essential here in terms of the county, but it really comes down, Becky, to the collaboration and the communication that we enjoy as an organization with all of our partners. When you look at healthcare in many respects obviously affects everybody. There's no one that does not have an impact where healthcare is concerned. And so at Robert Wood Johnson Hamilton, we simply don't look at patients as our stakeholders. We look at every aspect of the community as members of our community, as stakeholders within the success of the hospital.
Great.
And that's something I saw too. You know, starting out as a councilman in Hamilton, I joined one of the boards, the Young Professionals Board for the hospital. So we had that collaboration right from the start, seeing that as an important employer and as an important partner for the health in our community. And then when I moved on to the Freeholder Board, serving on the educational institutions for the boards for the technical school and the special services school district, and again helping to partner with them to transition to some full-time secondary educational programming at the technical schools, and the healthcare industry being one of the first that we piloted. And again, that's because of the need that we saw working with the healthcare providers in the community, and bringing that experience now to the legislative level has really been a boon for me, interacting with my colleagues and advocating for the changes that are needed for Mercer and for the state.
Great.
One of the things that I find very, very important about all this is that, yes, we are focused in the healthcare industry, but at the end of the day, Robert Wood Johnson Hamilton is one of the community's largest assets. It is a community asset. While the name on the front door is Robert Wood Johnson, it belongs to the community. And so our articulation is consistently, whether we're dealing with our community education programs or we're dealing with our Shakedown program in terms of childhood obesity or what have you, we are constantly focused on, so how does the community benefit from the services that we are offering?
Well, let's just point out that Robert Wood Johnson is not a bad name to lead with, no matter where you are. So, good name to have. Yeah.
Absolutely.
Let's talk about the quality of health in Mercer County residents. I mean, obviously, you're on the front lines dealing with people, but and Assemblyman Benson is chair of the healthcare committee. Clearly, you've got a statewide perspective. But from your local roots and what you know and what you see, how healthy is Mercer County? What are some particular areas of concern?
Well, chronic disease obviously is one of the major cost drivers. And then the work that we're doing now with accountable care organizations and the Trenton Health Team, which just received a significant grant, you're looking for what are the outliers that are driving some of the costs. Folks that are using the emergency room as their primary care and using multiple emergency rooms throughout the year that may tip the scale for cost, and trying to get them into a more efficient care system, doing the outreach of care that's proactive rather than reactive for hypertension, for diabetes, and other chronic disease management. Those are really the focuses that we do. And then looking for the shifting needs in a community. We're an aging community, so you have more needs for senior citizens. The hospital just, and Skip will talk about this, the new pediatric emergency department.
Yes.
So key for the needs that we've seen, especially as we have the shifts of Capitol Health moving some of their facilities out to Hopewell, and then the new hospital opening up in Plainsboro. All of these changes that are happening, we have to both react to and be proactive in reaching out to those changes in society.
So chronic disease, which is pretty much a problem across the board.
Correct.
But that's a bigger problem here in Mercer County.
Well, there are some very, very significant issues in Mercer County, and we look at the demographics of the county. I mean, there's a lot of work yet to be done. When you rate the health of Mercer County, clearly we have been heavily involved in a community needs assessment. This is a comprehensive assessment that's being done. It's being done in concert with we received a $250,000 grant. It involves all of the hospitals and all of the social service areas and all of the local health offices within the large majority of the county, and then Trenton has its own program going. So what we have looked at is what the real needs assessment will be, and this is one of the benefits that comes out of the Affordable Care Act in ensuring that we do this, and mandated to do it by 2013 so we can begin to set the stage for all providers as we move forward. And so, as Dan has said, as the Assemblyman has said, chronic disease is clearly an issue for us, but also looking at our demographics, give you a sense of this. In our county here versus other counties, we have a greater African American population versus a white or Hispanic population. Versus other counties, we appear to have more single female heads of households than other counties. We have a significant foreign-born, foreign-trained group in Mercer County, perhaps more significant than other counties in the state. And so how we begin to direct the delivery of care for those patients in those chronic disease areas, and our chronic diseases are not different than others, and obesity clearly is at an alarming rate. Give you a sense of that, in our Shakedown program, we had a child come in not more than a month and a half ago, a 14-year-old child who weighed in excess of 400 pounds. This is the first time in our country's history that it is anticipated, unless we get this epidemic under control, that the next generation will live a shorter lifespan than our
Exactly.
generations will live.
That is a shocking statistic.
It is extraordinary. Diabetes, clearly adult diabetes continues to ramp up and what have you. The issues of congestive heart failure. We are at the moment into a grant with the Robert Wood Johnson Foundation looking at 190 patients over a 2-year period of time on how we can prevent the readmission within a 30-day cycle of congestive heart failure patients back into the hospital. So there is a great deal of emphasis on this, and that is in large measure because we're moving from, in essence, an environment where it's been predominantly inpatient to more of an outpatient environment with the delivery of care. When you get to that outpatient environment, you really need to be able to ensure that when a patient leaves the hospital, that they are taking their meds, that when they leave, the follow-up appointment is being made while they are still in the hospital so that time doesn't lag in getting to the doctor and what have you. And so these kinds of transition programs are going to become far more prominent as healthcare reform moves forward.
And let's talk about that a little bit, because both of you are uniquely situated to look at healthcare reform as it impacts all of New Jersey and as it impacts you as a hospital CEO. We know that there are a number of people who are anticipated to be moving into the healthcare system. Estimates range from, what, 150,000 to, I've heard 450,000, which is truly frightening. And then, obviously, as an economic incentive, you've got to control costs. You've got people coming in who may or may not find a doctor, because we know there's a shortage of doctors. Does that, you may have more people showing up in your emergency rooms, which is obviously not going to be a good thing. I mean, how do we educate people to take advantage, first of all, of the options that are going to be out there? And how do we make sure those options are put in place? I know we're still waiting on the health insurance exchange we talked about back in May in New Jersey.
And I think since then, the update there is, since the Supreme Court case decision,
right.
First and foremost, for the health of hospitals and everywhere else, we need to make sure that the state accepts the Medicaid expansion. I think that's very crucial.
Absolutely.
These patients are already in the emergency room. They are covered very barely through charity care. This provides us, it's not a perfect reimbursement, but that reimbursement is at such a better level for hospitals and the health of our hospitals. We can't succeed in this future of healthcare reform without having strong hospitals on a strong financial footing.
And what's the status? That's the Medicaid waiver?
It's because the decision under the Supreme Court is now optional, so it's going to be up to each state. And so it's going to need to be an acceptance between the governor and the legislature. I believe our legislature is on board. The governor has not made a final decision yet. He wants to look at the long-term costs. But I think if we look at the long-term benefits to New Jersey residents, both in their terms of health and the long-term costs for not receiving the quality care, and then the costs on our hospitals, I think it should be an easy decision. I hope that decision happens after the election in November, and we have a certainty going forward so that our hospitals know what world they're going to be operating on. And I think that's okay.
Well, Dan raises an interesting point, and there are a number of aspects of healthcare reform that I think are very, very important as we move forward. One, of course, is the exchanges. And should the state of New Jersey itself fail to act to implement an exchange, then the federal government under the Affordable Care Act will step in and institute an exchange so that there will be an exchange. The issue is, will it be controlled by New Jersey or will it be controlled by the federal government?
Will that make a difference in your world, do you think?
It won't make a difference in our world. I do think it makes a difference to the state of New Jersey, given New Jersey's fiscal constraints. I think it makes eminently good sense for New Jersey to be able to get the exchange in place, as the Assemblyman has indicated, simply because in the first 3 years, there's 100% reimbursement or 100% funding from the federal government. Thereafter, the funding drops down to 90%. The second aspect to that is now that you're moving in the exchanges, you're moving to cover people who've not had coverage. And so the exchange will actually should, if it's 400,000 of the 1.2 million New Jerseyans without insurance, if they are taking off of those rolls, should reduce the implications of charity care. Further, we also think that from what we have seen in the hospital environment, more often than not, people who receive charity care, because they do not go to a doctor for preventative medicine, more often than not, they wait to the very crisis point.
Until it's extreme.
And so it becomes extreme, and so it's more catastrophic and what have you. If there's insurance in place, we firmly believe as an industry, people will look to get more care, which ultimately will lead to greater prevention. The essence behind the Affordable Care Act is really not only the issue of coverage, but it is also the issue of wellness and prevention. Those are really the two hallmarks of the Affordable Care Act. Yes, the individual mandate that the court has ruled on will give people the option, but by virtue of providing for greater prevention and promoting wellness, we will be in a better place as a society. On the other end of the Affordable Care Act and the Center for Medicare and Medicaid, what's happening is a greater emphasis on outcomes, clinical outcomes, and value. And so we, as an industry, have entered into a window called value-based purchasing, where some of the dollars that are paid to us by the Center for Medicare and Medicaid are now put at risk. And the benchmarks that are out there for outcomes then measure whether, in fact, you've met that test. If you fail to meet that test, then those dollars will be taken away from you. So it's bringing an incentive to healthcare providers to do a better job in producing clinical outcomes than what has happened in the past.
It's really a double-edged sword.
Yes, it
Affordable
is.
Care Act is a double-edged sword for you all. Before we move on to that point, let me just ask, we talk about charity care a lot in New Jersey, and what does that really mean to you? When you walk into your hospital emergency room, give me just a snapshot of what you see and how that could be different if we had more insured people.
Well, if we had more insured, well, first off, there is a federal law that says that if someone shows up, and it's an appropriate law from our perspective, that if someone shows up at the front door of the emergency room, we will give them care, regardless of their ability to pay or not pay. In Hamilton's case, we see a very small piece of charity care reimbursement. So our reimbursement is around $500,000 for about $6 million worth of care that we give each year and what have you. And we willingly give that care to ensure the person's health. But with the exchange and with the insurance coverage, that delta, if you will, of the $500,000 to $6 million in large measure would get covered. And so the hospital would be reimbursed for the care that it's currently giving versus where we currently are, where a lot of it is not reimbursed.
Now, Skip, I would characterize you primarily as a businessman. I've known you
Yes.
in a few phases of your life, a few incarnations. So when you look at the hospital as a CEO, first of all, how do you close that gap with the cost of the service that you're providing? And when you look at the changes that are, the incentives that are coming, what I thought was kind of a devastating report the other day on the actual cost effectiveness of electronic medical records. You may have seen the report. It was, I forget who did this study. It was in the Wall Street Journal. But they're actually saying that this is not incentive. I mean, do you think that you're going to be charged to provide these services, EMRs, things like that? Does that actually produce a cost savings?
I'm not sure that it produces a cost savings. I mean, the concept behind it is that we will reduce medical error. And I do think we will reduce medical error by having an electronic medical record. And so why do I say that? Because if one looks at a chart and the legibility of a physician's writing.
Legendary, yeah.
Yes, correct.
Yeah.
So that I think will help. I also think that we will move from a situation where the potential exists of oversubscribing different medications. And so if it's in a medical record that's clear and understood, you'll be able to evaluate better whether in fact that prescription should be aligned with that prescription and what have you. And in the final analysis, I think what that will produce is a better clinical outcome. How we will deal with this and how the industry deals with it is we need to become much better at assessing the number of tests. So should those tests be done as an inpatient, or can those tests be done as an outpatient versus the utilization of inpatient services and whatnot? Can we reduce the length of stay? In my time at Hamilton, the Medicare length of stay at one point was 6.50 average days length of stay. We now have that down to 5.04 average days length of stay.
And you've done that without impacting the quality of care.
And we've done that, as a matter of fact, Becky, the quality of care has gone up.
Terrific.
So I think that that is a very, very telling feature. So being able to reduce the length of stay and aligning the incentives between physicians and hospitals for the future, I think is a key to being able to afford and deal with healthcare reform.
Yeah, the cost savings on electronic records, I think initially were probably oversold. There's so many ancillary benefits, as Skip just mentioned. And I think if we're moving to a world in reform, healthcare reform, where we're going from quality care to quality outcomes, you have to have that digital world. And how can this be the last industry that's not moved digital? If all the tracking that we're going to need to have better outcomes, to make sure that we're being more cost efficient, to make sure that the patient has more control over their own care, to make sure when they move from one doctor to another physician that they're not ordering duplicate tests, and they can carry all the information over to that new healthcare provider. All of these things are so important in a future healthcare world that we're trying to get to. So regardless of the health savings, I think we'll see broader systemic savings in the long run that you get from having electronic records.
And that kind of underlines the point that we had touched on a minute ago. Once you get these people into the system, all of these previously uninsured, it's so much is up to the patient. As you said, a patient really has to be, their own advocate. So how do we get to the point where health education, health literacy is an achievable goal? I mean, how are we doing on that goal?
Well, I mean, from our perspective, we have, over at our Center for Health and Wellness, which is located here on Sloan and Quaker Bridge Roads, it's 88,000 square feet of medically based fitness. Importantly, what we do out of that facility is we run our community education program. We have a medical advisory panel. That medical advisory panel puts on a number of classes, screenings for people, and so we get a substantial amount of the regional population in for those. We touch probably 150,000 lives through that. Yesterday, for instance, the state this week is into falls prevention, because falls are a very, very critical element in our healthcare system. And what people don't realize is what falls cost us. The average fall costs us $65,000 when somebody gets injured or hurt.
And we think of that maybe as a problem with the elderly, but it's maybe across.
It's across lines. It's not just the elderly. More often it happens in the elderly, but it does happen in every other area. And so yesterday we held a symposium on that, and we had in excess of 175 people at that. So getting that message out to all generations is important, and that is what we do with our community education program.
And all the different health institutions in Mercer County, the key is collaboration and partnership. Again, that's where the grants for the Trenton Health Team, looking at down the line with an ACI, the Accountable Care Organizations, working together to see where the costs are. We have data showing fall prevention is key. Looking at these areas of hypertension, diabetes, high blood pressure, all these different areas of chronic disease management, working with all the different partners, especially primary care physicians, to say, tracking their patients, say, well, they haven't come in for a while. Let's make sure we make that call out to see how they're doing, and partnering with our pharmacies as well. The pharmacists oftentimes, especially with chronic disease management, see the patient more than everywhere else. So making sure that they have the wellness programs and they can direct to the community outreach that the hospitals are providing, or that other groups like the Henry J. Austin Center in Trenton that provides a lot of educational outreach and provides a lot of primary care into the greater Trenton community. Having those partnerships between all the different actors for that quality outcome, not just the quality care when they enter into the system.
And can you speak a bit more to that? Unfortunately, George Stokes, who's director of Henry J. Austin, the FQHC, one of the FQHCs, right, Mercer, was not able to be here today. nor was Jim Brownlee, who heads the Trenton
Yes.
Health Department. And I know that Trenton actually just exceeded standards. Is that right? With
Yes, the care, and I serve on the board for full disclosure of Henry J. Austin, and just recently joined. But the efforts for them to move from, they've already moved from a clinic model to moving to same-day appointments, moving to healthcare teams within the group so that you're seeing the same doctor every time you come in. So you have that relationship with the primary care physician. And now they're moving towards the medical home model, which is again being encouraged through the ACA Reform Act. And so again, all of this is to build a relationship with the patient, making sure that we're not just worried about how quality of care is given when they're in the facility, but to make sure, did they go see the specialist as a follow-up? Or if they've been in the hospital, did they come to follow up to make sure the tests were read by their primary care physician? And really building that relationship all around to make sure that they're staying on their meds, that they're seeing the social worker to make sure any other issues are had, and really making sure that follow-up occurs, because again, they're going to be measured on that quality outcome.
Well, FQHCs are really the safety net. I mean,
Yes, they are.
Your emergency room is largely a safety net.
Yes,
You
it
know,
is.
How are we doing in Mercer County in terms of making sure that safety net is there for the people who need it?
I think the safety net is there, but I think there is a real strain on the safety net. And I think that the safety net transcends just the areas of healthcare. I think that it goes to a number of the social service agencies that everyone works in collaboration with as healthcare providers. And so I think that it is at the moment, it is strained given the economics facing the state and given the economics facing the region. You know, we're seeing a great deal of strain that is going on there. There are also gaps in services here. Behavioral health, there's a real gap in behavioral health in the region. And what we are seeing is an increased incidence of just to the point where it becomes unmanageable stress for people. And so what we used to see was a greater incidence of suicide ideation in the elderly because of chronic illness and depression. What we're beginning to see is that working its way down into the more general population. And it's not uncommon now for us to see a 35-year-old or a 40-year-old or a 50-year-old, quite frankly, who's been through a great deal of trauma of having lost a job, having lost their health insurance, having strains within their family life, become a candidate for behavioral health issues. That
And
is
actually,
clearly.
I think I just heard yesterday that suicide is now the leading cause of death in America, where it was accidents before. Suicide is now the leading cause of death.
Well, it's definitely, and behavioral health really is probably the most significant gap. And then obviously as we have a changing complexion in our society, especially here in Mercer County, higher immigrant population that Skip talked about earlier, we have to make sure that we're providing care in a culturally sensitive manner and that we're providing that for different cultures. It's not just dealing with one or the other. Right. And understanding that means a broad, the full, yes, and the full gamut of countries that we have folks here.
How do you address healthcare disparities at your hospital? Cultural?
It's a lot of training.
We have a lot of training. We do a lot of training on the issues of culture and the implications of a different cultural setting for individuals. And we, as an institution, as many institutions, as Dan just said, I mean, we deal with an array and a gamut of individual cultures. It's not just, if you will, sort of the American culture. It's who's an Asian American, who comes from a Muslim background, and what have you. And it's very important that we be respectful of those cultures when they are in the hospital, because it's essential that we are collaborative with the family members and what have you. So it takes a great deal of training, and we have a very, very significant training component that is an ongoing training component in the hospital.
So many people think it's just a language barrier, but obviously cultural disparities
Right.
transcend that.
Oh,
And-
it's far greater than that.
Right. And there's not one monolithic Hispanic culture or one monolithic Asian culture. There's a lot of differences within there. And again, a lot of it's, learning to ask the right questions and asking, well, what are the preferences when there's an intake of the patient, understanding what are their expectations based on that. And plus, again, training is key. But with this economic downturn, as we talked before, it's providing unprecedented levels of stress on people that may have never had that in their life. This may be the first time they've experienced a downturn like this. Maybe the first time they are jobless or finding themselves with healthcare needs without knowing where to turn. And because of that, the need for this population to let them know there is help there, and it's not just the emergency rooms, but there are the FQHCs that they may not even know exist,
Right.
and how to access. So whereas the CARE Act, we talk a lot about the coverage side of things because it's primarily an insurance coverage reform. The issues of access are also a part of that. And that's where the Trenton Health Teams, the Accountable Care Organization, dealing with access issues and trying to identify gaps. And then ultimately it's a discussion about cost.
Right.
And there's some of that involved in the reform, but as we go, it's not just covering and making sure that you have efficiency of care, making sure they're seeing primary care and preventative care, and how do we cover that, but then talking about reimbursement rates. And we spoke just before the panel started about we have issues with the sequester automatic cuts to Medicare reimbursements that can have significant impacts to our hospitals and to our doctors. And what does that mean for care just as we're getting started on the reform path line, and the importance of working with our federal representatives and our other elected representatives to understand what that impact is and the need for everyone to work together in a bipartisan manner to make sure these negative impacts do not occur.
And one thing we haven't even touched on is the shortage of primary care physicians in New Jersey, so that once we get everyone previously uninsured into the system, who takes care of them?
Well, I think that we have to look at the primary care model in a little bit different light as we move forward. And while we have a shortage of primary care physicians per se, there are also other avenues by which we can see the population. Physician assistants,
Right.
Advanced practice nursing,
Right.
Nurse practitioners, all I think can become a component of the primary care network. We're never going to be able to, I think, in an appropriate level of time, given how long it takes for a physician to become a physician, be able to grow all these primary care physicians in the immediate term. Perhaps over time, as we realign the incentives for primary care physician versus the subspecialists. So today, an average primary care physician makes about $175,000 a year. Sounds like a lot of money, I'm sure, to a lot of people, but when you value the education and the training and what they do and where they're at, quite frankly, the subspecialists are making far more. And so the ability to align the incentives for primary care physicians is important, and then adding to that primary care tree with the advanced practice nurses, nurse practitioners, physicians assistants, I think will be essential for us to be able to cover all and deal with all of these lives that will be covered in the future.
And some of that depends on legislative, I think the barriers are there now to that happening, right?
Correct.
Are we
There are
behind?
changes that we need to make at the state level on what type of care advanced practice nurses can give, defining better what each person's role based on their educational background and training, and what are the requirements for medical teams or medical homes have. So it may be one or two doctors that are seeing as the primary care that are guiding the full patient pool, but they have a number of advanced practice nurses and other physician assistants that are on staff to make sure that care can be seen efficiently, and then that follow-up can be done in a cost-effective manner. So I think roles are going to change, and I think there may be some bumps along the way in doing that, but I think having that discussion now as we have the discussion on the exchanges and the Medicaid expansion, it's important to have these discussions now among all the different actors to find out what's best moving forward.
And clearly, as you mentioned, in New Jersey, we're one of the states that's apparently waiting to see the outcome of the presidential election.
Correct.
To move forward with things. I mean, do we really anticipate that there'll be progress made after the elections?
Well, my hope
Or
is,
not, depending on who's elected, I guess.
I think the governor, from everything that we've heard, and the legislature, all agree that it would be a mistake to let the federal government decide how the exchanges are set up, that we want to have a New Jersey-centric model. I think after the elections, if things do not change drastically from where they are now in Washington, we can expect to see some cooperation to come out. I think the big battle is going to be over whether the health exchanges are a passive exchange versus an active exchange. Obviously, I have my preference on active. I think making sure that the care and the insurance that someone purchases meets their needs of care is so important, so they actually have that coverage and access that they're going to need. And I think that's important. Healthcare is as complex as it is. So when deciding, just as we do with Medicare or with the prescription drug benefits, that you have places you can reach out to get advice back on what's best for yourself.
And the managed care providers, the Aetnas, the Cignas, the Horizons of the world are looking at what kind of a product they will have for the exchange participants. So they are preparing for the exchanges as well. And I just think that we will ultimately, once we get past the national election, somehow, some way, New Jersey will come together in the legislative aspect of it and in the executive branch, and we will end up with our own exchange here.
And let me just make it clear, because we're a nonprofit organization. We're not making a political commentary,
Sure,
but just from a practical perspective, the difficulty of moving forward without having any kind of a clarity.
Well, we have to decide as a state what minimum benefits are provided. Every state's making this decision right now. California is deciding whether acupressure and other types of care are involved. We have to make our own decisions about what's right for New Jersey, and we have to keep in mind that cost versus the vouchers that will be provided through the ACA to families, to make sure that those two match up and there's not such a gap that people rather pay the fine rather than purchasing care.
So let's just close. We're almost, I didn't think I'd have a problem filling 45 minutes with you two, so that's fascinating. But let me just, and I know you got to hear some of the previous panels as well. One of the questions, the thermometers we take as we go around the state is, are you generally optimistic about the quality of health care, say, in Mercer County? Generally positive, and what would you say has had the biggest positive impact on health care in the county in the past year?
Well, I'm very optimistic about in Mercer County, and I think that's mainly because we have leaders like Skip and George Stokes and at each of the different hospitals, and they are working together. We have the Trenton Health team that are working together to make sure outcomes are good. So I'm very optimistic about where we're going for care. I want to make sure that the state is providing the partnership and the leadership it needs to make sure that we can support the local leadership that we're seeing here in the county.
I'm very optimistic about the quality of care in Mercer County and the future of the quality of care in Mercer County. And I'm particularly, I think the last year, the most beneficial thing that we have done is come together, collaborate on this community needs assessment. Whether you be at one of the hospitals, or you be a local health officer, or you be a social service agency, everybody pulling together to understand what the needs will be in the future, I think is very, very important and essential. And if there's one thing that I think is overriding, was the ability for everyone to come together and talk about those issues and ensure that those issues are front and center for every healthcare provider and social service agency to be focused on as we move forward in the next several years.
Terrific. Thank you both so much for being here with us today.
Thank you.
And that concludes our segment of State of New Jersey, State of Mercer County 2012. Thanks for being with us today.